as we now are living in an era where quad refractory and penta-refractory patients are becoming increasingly common, we do need to have a strategy on how to tackle these patients. The experience that we published was drawn from our own single center experience. We had about 54 patients who had had bendamustine and prednisone, and about 106 patients who had had the combination therapy of dexamethasone with Cytoxan, Etoposide, and Cisplatin in our institution. And we found that of these, 27 patients got bendamustine and prednisone for quad or penta-refractory disease, and about 31 patients got DCEP for the same demographic of patients. The majority of patients were penta-refractory, about 3/4 to 80% of patients. These patients had a median age just over 60 years, and the vast majority of these patients, 80 to 90%, had had a stem cell transplant. And these patients were heavily pretreated, as we said. They were on an average about 4.5 years or more from their time of original diagnosis. And what we found is that with the treatment of bendamustine and prednisone, about a fourth of patients, roughly 26% of patients, responded. What we did observe was the response rate was higher, close to 40% for patients who had not seen Cytoxan, which is structurally related to bendamustine. And for the DCEP patients, we saw a response rate of close to 40% overall, and did not seem to be impacted on whether they got Cytoxan before or not. These patients, because they were heavily pretreated, did have a somewhat modest progression-free survival, with the progression-free survival in the bendamustine prednisone cohort being about 1.5 months versus a little over 2.5 months for the DCEP cohort. For those who responded, the duration of response was about 6 months or more for bendamustine prednisone and 4 months or more for DCEP. On an average, patients got anywhere from 1 to 8 cycles of bendamustine and prednisone, and DCEP from 1 to 5 cycles. This overall survival of the bendamustine prednisone cohort was roughly about 8.5 odd months, in the DCEP cohort about 6 months. But again, these are totally different cohorts of patients, and there's no way you can comment on the merit and demerit of the two regimens. This is not meant to be a comparison. In fact, about 16 patients actually received both therapies, with 12 patients in the bendamustine prednisone cohort getting the therapy first and going on to DCEP later, with about a 33% response rate when we did that to DCEP. But when we, in 4 patients, gave DCEP first and then gave bendamustine and prednisone, unfortunately, none of those patients did respond. So this is, as I said, a single patient experience. We have emerging therapies for this cohort of patients in the future. We know that selinexor was recently approved for such a demographic of patients. Our cohorts of patients were in an era before selinexor became available. Certainly that does provide an option for a similar cohort of patients going forth. And hopefully in the not too distant future, we will have additional therapies to offer these patients that are directed towards the B-cell maturation antigen, with the possible approval of the antibody-drug conjugate in a few weeks, and perhaps by the end of the year, a CAR T-cell to BCMA coming on market as well. So these patients are in need of newer therapies, and it is good that we're starting to have options for these patients. This cohort that we have in our publication provides a little more granular detail. These regimens have been around for a long time. They are not any new regimens, but the fact that they work is gratifying. We have seen larger cohorts of patients, like the Mammoth series published in the Journal of Leukemia in the last few months, several hundred patients who were quad or penta-refractory. There too, there was a cohort of patients that were treated with bendamustine, prednisone, and PACE-like therapies to which DCEP would qualify. But there wasn't as much granular detail. So I think that our single center experience hopefully provides a little more granular detail for patients needing this kind of treatment. We will have newer therapies in the future, and how to choose between these various modalities of therapy is going to be something that we will have to face. And how we choose between an antibody-drug conjugate or CAR T-cell, or for that matter, to follow thereafter bispecifics to BCMA, is going to be a topic that will only with time give us answers. I think that the antibody-drug conjugate from GlaxoSmithKline has shown activity in a highly refractory population. However, the durability of the responses from the DREAM2 study published recently is not of the same magnitude as that seen with the CAR T experience from BB2121 that was published in the New England Journal of Medicine and updated in a press release subsequently. As both of these therapies are expected to be on the market within the next year, we are going to be faced with our own patients asking us how we should choose between these therapies. One of the things that is clear is the antibody-drug conjugate certainly is an off-the-shelf product that can be delivered to patients within a day or two if required. And so for a patient whose disease is gathering pace, it is often not feasible to wait 6 to 8 weeks that it can often take to get a CAR T to the patient. So for that patient, though the benefit in terms of durability of an antibody-drug conjugate approach may be more modest, it would be often more practical and perhaps sometimes the only thing that can be done in a situation. The other thing going for antibody-drug conjugates is that these can be given in a community doctor's office where most of the myeloma, at least in the United States, is still tackled. And these drugs, antibody-drug conjugates, are something that community oncologists have had the experience in other diseases and can be safely administered in their own premises, whereas the use of CAR T cells is going to be something that, at least in the near future, is restricted to larger academic centers and tertiary care hospitals, which are often far removed from the patient's place of residence. And once you do embark upon this, apart from the wait time, patients do have to live in the vicinity of the transplant center or the CAR T cell center for a month or more. And that, I think, brings its own logistical challenges for patients. So I think that if you have a young, healthy patient whose disease doesn't require immediate attention and can be bridged for a while, then certainly the most effective therapy for that patient is going to be a CAR T cell, and that would be one's first choice if the patient is seen in my practice. But the antibody-drug conjugates will have advantage in terms of ready availability in even smaller centers. One of the downsides of antibody-drug conjugates is the fact that these that are currently in clinical trials do have side effects. The one from GlaxoSmithKline has keratitis as a side effect that requires patients to undergo ophthalmological examinations, and that is something that is being done before every cycle in clinical trials. How this is mandated by the regulatory authorities post-approval will also determine the ease of administration of antibody-drug conjugates as you may have to coordinate the care with an ophthalmological examination, which can sometimes be, in certain areas, challenging. The use of the CAR T cell has its own challenges with the cytokine release syndrome and possible neurological toxicity. And to add to that, also the cost of the treatment can be prohibitive for some healthcare systems. So I think we have pros and cons to each modality of treatment that we will have to individualize patient care based on the kind of patient that we are seeing.